Just 1 minute. Yeah, it's online right now, Professor.
Okay.
Okay.
So you tell me when to start, right?
All right. All right. Just let me put this without sound here. Perfect. So, hello everyone. My name is Rodolfo Gomes Dias. I am a scientific director of Brazilian Association of Cardiothoracic Residents here in Brazil. And this is Professor Volkmar Falk, who is the chief and director of the department of Resynchronisation Berlin, the heart center in Berlin. Hello, Professor. Good evening.
Hello. Happy to join you.
Yeah, thank you very much. And today, the professor is going to present to us the left ventricular assistant device, the state of art, and the latest news about that device. Thank you very much, Professor, for this presentation again.
Yeah, thank you for your introduction. And I will start this lecture. How much time do we have, by the way?
As much as you prefer.
Okay,
yeah, could be 1 hour, 2 hours. Yeah, that's fine.
So I would like to start, of course, before we talk about LVADs, to give a definition and a few thoughts on heart failure. So what is heart failure? It is defined as an abnormality of cardiac structure or function which leads to failure of the heart to deliver enough oxygen at a rate that is commensurate with the requirements of the metabolizing tissues. So that's a very broad definition of heart failure. And what it basically means is that the heart is not able to pump enough blood through the body to supply all organs with enough oxygen. If we follow that definition, it's immediately obvious that, of course, an LVAD, which can potentially pump more blood, will also increase the oxygen delivery to the body and therefore can help to treat heart failure. If we briefly review the pathophysiology of heart failure and of chronic heart failure, because we're focusing a little bit on chronic, then we find often any injury to the heart that will lead to a damage of the myocytes or the extracellular matrix, will change not only the geometry, the size and the shape and the function of the heart, but also will affect cardiac wall stress. And this process where the heart undergoes changes is called remodeling. Hang on, what's happening? Whatever injury causes this, these changes will then lead to a systemic neurohormonal imbalance, and I will come to that later. This then will trigger fibrosis, apoptosis, so cell death, cause hypertension, hypertrophy, cellular molecular alterations, and myotoxicity, and that can then lead to remodeling and progressive worsening of the LV function. And it will also cause hemodynamic alterations, which patients then experience as symptoms, and salt and water retention. So this explains the morbidity and the mortality associated with heart failure. Additional arrhythmias can complicate things, and the end result is heart failure. The typical symptoms: dyspnea, edema, and fatigue. And of course, this is a vicious cycle. The more cells die during the process, the more damage is done. This will, of course, accelerate the process. This is just an example of ventricular remodeling that we see typically after myocardial infarction. So we have here an area of local injury, an acute infarct, let's say here in the apical region, there will be a fibrous scar formation. And as a compensating mechanism, the residual healthy myocardium will show some degree of hypertrophy. If not treated, this will then lead to a thinning of the scarred wall and eventually aneurysm formation. The residual myocytes will undergo hypertrophy, but also we will find an increase of interstitial collagens. There's a lot of risk factors and comorbidities that contribute to the development of heart failure, and you're well aware of all of these. Typically, our Western civilization lifestyle, hypertension, coronary artery disease as one of the leading causes, and of course other causes of heart failure are myocarditis, or in rare cases chemotherapy or any other toxic drugs, or in a very few cases peripartal cardiomyopathy in pregnant women after delivery. All these risk factors can cause myocardial infarction, left ventricular hypertrophy, and this then will lead to systolic and diastolic dysfunction, which can be subclinical in the beginning, but at the very end, when the patient develops symptoms of heart failure after years and months, there's typically two forms of heart failure that we see. We will focus a little bit on HFrEF, but I will shortly explain the differences between what we call now HFrEF, which means heart failure with reduced ejection fraction, and heart failure with preserved ejection fraction, HFpEF. If we look on this side, HFrEF is a typical disease that we see after myocardial infarction, myocarditis, which is characterized by volume overload, increased diastolic pressure, which then increases the diastolic wall stress. This adds new sarcomeres, there's chamber enlargement, eccentric hypertrophy. The end result is a dilated and volume overloaded left ventricle. It's characterized by eccentric hypertrophy and thinning of the walls. So typically these ventricles are huge, and I will show an example in a minute, and very large. On the contrary, HFpEF is a different disease. It's usually caused by pressure overload, which can, for example, result from chronic hypertension. It will lead to increased systolic pressure and increased systolic wall stress, which also has a different pathology pattern, because you see new myofibrils and thicker myofibrils, wall thickening, concentric hypertrophy. So this is the typical small ventricle but hypertrophied ventricle. It can also lead to low output. So these patients, despite the fact that they have normal systolic ventricular function, can have symptoms of heart failure. It is sometimes more difficult to diagnose and also very difficult to treat. We will focus a little bit more on HFrEF, and this is a typical picture of a patient who has long-standing history of heart failure, a massively dilated left ventricle. You also see that this wall motion is not synchronous, so the septum and the lateral wall are not in sync, which may be a good case for cardiac resynchronization therapy, which I explain in a minute. So what happens if we have this type of disease and cardiac dysfunction with large dilated ventricles? This will trigger the activation of three compensatory neurohormonal systems. And this is meant to be mechanisms to maintain cardiac output and organ perfusion. So it's a typical reaction of the body to a dysfunctional heart. And this is the autonomous nervous system, the renin-angiotensin system, and the neprilysin system. So the first two, the sympathetic nerve system and the renin-angiotensin system, they are activated in response to reduced cardiac output, and their short-term effects are beneficial in early heart failure, but their long-term activation exerts unfavorable effects, mainly because they increase the vascular resistance. On the opposite, we have the neprilysin system, which opposes the actions of the former two. And if we put this in one graph, so we have an early activation of the sympathetic nervous system, epinephrine, norepinephrine act on the alpha and beta receptors, which leads to vasoconstriction. At the same time, the RAAS system is activated, which will also lead to vasoconstriction, an increase in blood pressure, increased aldosterone secretion, hypertrophy, and the induction of fibrosis. The NP system is an opposing force which leads to vasodilation, but usually it's blocked in heart failure, and the result is then volume overload. New drugs like neprilysin inhibitors will prevent neprilysin from being inactivated, and therefore be very effective in the treatment of heart failure. And you're probably aware of the studies on ANIs that were published just recently. Now, what are the symptoms? Typically for left-sided heart failure, dyspnea, cyanosis, fatigue, tachycardia, confusion, and cough. Right-sided heart failure, in addition, you find, of course, edema, abdominal pain, usually due to ascites and enlarged organs. And we will see also liver function. At the very end, usually the synthesis function of the liver will be compromised. And that is actually one thing that for LVAD implantation is a real problem. So the typical patient is seen here: fluid retention, lung edema, pleural effusion, and of course, shortness of breath are the typical symptoms. We usually divide the severity of heart failure according to the New York Heart Functional Class, and it has a prognostic impact. If you compare patients who are New York Class 2 to those who are New York Class 3 and 4, you see a marked difference in survival. And note that for the end-stage heart failure patients, New York 4, 20% die within 6 months after the diagnosis. So it's a very bad and chronic disease. Of course, we say it's a chronic disease, but usually the typical course of the disease progression is like this. We have a chronic decline in function, which is triggered by acute episodes. And after every of these acute episodes of decompensation, the patient is in a worse shape. And this is also associated then with an increase in mortality. Heart failure is a global killer. 2% of the population suffer from heart failure. 1 out of 5 of the patients in the age of 70 to 80 suffers from heart failure. This will add up to about 26 million people worldwide who are suffering from end-stage heart failure as we speak. And this will increase because we're facing an aging population and an increase of the prevalence of risk factors. And also because we have better therapies for myocardial infarct. So it used to be that most patients would die from myocardial infarct. Now these days, with acute PCI being delivered everywhere, this has changed, and more people die from heart failure than from myocardial infarction. We have alone in Europe 1 million hospitalizations due to heart failure per year. So it's a real burden for the healthcare system. 1 out of 4 patients will die within 1 year after the diagnosis, and 50% usually die within 5 years of diagnosis. So it's also a very deadly disease. And if you compare to the mortality in cancer, the green line here is heart failure. And you see that it parallels some of the cancer lines and is actually worse than some of the major cancers that people die from. So it's a deadly disease, and mortality is higher than for many malignancies. You can also call it a malignant disease because it is. The treatment of heart failure is typically based on medications. ACE inhibitors, of course, play a large role. Lately, ANIs are prescribed more often, and we will focus on device therapy. Maybe just a short look on what we have available, because for the last couple of years, we have used implantable monitoring devices who can measure pulmonary artery pressure as an early sign of decompensation. If you look at the course of the patient, you can detect increased filling pressures, which can be reflected in an increase in pulmonary artery pressure very early, long before the patient shows up in a hospital or notes a weight change, which is the classical measure that someone can do at home to monitor the course of heart failure. So there is a large latency between the early onset of heart failure and when the patient actually experiences anything that he can measure. And so the idea is that the patient will be captured early in order to prevent hospitalization, adjust medication, and try to impact the progression of heart failure early. And one device to do this is the CardioMEMS, which I show you here. So it's an implantable sensor. It is placed in the pulmonary artery. It's a pretty simple procedure. You have a catheter, and then the device is actually placed here and sits in the pulmonary artery, and it can then measure the pulmonary artery pressure. And these data can then be read out by a device. The patient is basically laying down on a pillow, and there's a transmitter, and the transmitter takes the data and sends them to the hospital. In a recent study, it could be shown that those patients who are managed this way, so who have an early monitoring of their pulmonary artery pressures, have significantly fewer heart failure hospitalizations, which is probably a very successful story, and may actually help a lot of patients to have less hospitalizations. It also therefore got a mention in the latest heart failure guidelines, the European guidelines. It's a very weak recommendation 2B because there's very few data, but the evidence is there because there was a randomized trial, and that's level B. Now, the next step, of course, would be consider CRT treatment, so cardiac resynchronization therapy, a pacemaker who has 2 leads to provide synchronous pacing of both the septum and the posterior wall of the left ventricle. And as a matter of fact, in some patients, this will improve symptoms, and it will also reduce functional mitral regurgitation. So there's a number of recommendations. Basically, what you should remember, it is only recommended in HFrEF, so in those patients we are talking about. And if the ejection fraction is less or equal to 35% and the duration of the QRS complex is 150 milliseconds, the recommendation is less for those patients with a QRS duration of 130 to 150, and below that there's no indication. There was a negative trial. It is also used when patients have HFrEF, even if the ejection fraction seems is still good with 50%, but if they have AV block, that requires pacing. So long-term right ventricular pacing in patients with AV block is not good, and this is of particular interest because we see a number of patients after TAVI who have AV block and who need right ventricular pacing, and probably for a lot of them, especially if they're younger and have a long-term RV pacing, a CRT is probably needed. There's other indications, but these are the most important ones. Now let's come to LVAD therapy. When is it indicated? So let's assume the patient has already had full medication, has been checked if he's a candidate for CRT. Eventually, functional MR has been treated with mitral clip or surgery. As you know, there were 2 large trials for the mitral clip in functional MR, one positive, one negative, and this would need a full hour of explanation what the differences between the trials are. The bottom line is that in patients who are probably have advanced heart failure, but ventricles that are not extremely large and functional MR that is disproportionate, meaning that it's very, very large mitral regurgitation, that in this particular group, the mitral clip can actually prevent rehospitalization, and also may actually impact survival. For LVADs, we have similar indications as for cardiac transplantation. You see here, these are from the European guidelines. Ejection fraction should be less than 25, peak VO2 less than 12 milliliters per kilogram per minute. the patient should have 3 heart failure hospitalizations in the previous 12 months without any obvious, an obvious precipitating cause. He should be on inotropic therapy, that's another indication. Or we should witness progressive end organ dysfunction, be it renal or hepatic, due to reduced perfusion and inadequate and not to inadequate ventricular filling pressures. Of course, we always check for the absence of right ventricular dysfunction and severe TR, and I come to this later. What is important is that if you consider LVAD implantation, it should be done not too early because it also has a lot of complications and side effects, but also not too late. So there's a sweet spot. I come back to the slide which I showed you earlier. We see the increase in mortality with increasing number of episodes of decompensation. And we don't want to implant an LVAD here. This is certainly too early because quality of life is still good and mortality is still low. But then when the patient starts to come more often to the hospital, and this is reflected in that recommendation, 3 hospital visits. So that particular patient would probably be hospitalization 1, 2, 3. So here, somewhere here is the sweet spot for LVAD implantation. And the principles are pretty simple. Usually we have a continuous flow pump these days, which is put in the apex of the heart. And this pump then sucks the blood out of the ventricle and into the aorta, typically the ascending aorta. So that's the configuration that most people would choose. It's a very simple procedure that can be done on the beating heart with no problem. Of course, we have a drive line that leads to the battery pack and a controller, which the patient can wear as a belt or backpack. There's various options here. So that's the classic system, and I will show you shortly a video of implantation. So this is a patient, obviously, with severe heart failure. You saw the massively enlarged left ventricle. In this particular patient, we use a bilateral approach for implantation of a hardware system. We have put 2 wires into the groin to secure access should cardiopulmonary bypass be needed, so it's a safety measure. A thoracotomy is made in the 5th interspace to the left, and the apex of the heart is exposed. Simultaneously, you see here that with a second intercostal space on the right, we have exposed the aorta, and then we anastomose the outflow graft to the aorta. At the same time, the connecting ring is placed on the apex of the heart. We use felt-plagiated sutures, then the drive line is tunneled out through the lower quadrant of the abdomen. Make sure that the outflow graft is connected well to the system. Then a cut is made into the apex of the heart. And of course, this is a moment where you need to be fast. We use this coring tool to core out a piece of the left ventricular apex, and then the pump is inserted into the ring, and all you have to do then is to orient the cables. And you see here the outflow graft to the aorta. The wounds are closed and the system is immediately operable, and you see here with a flow of 5 liters. So this is one way of implanting the LVAD. I can show you another example, which we prefer for patients who have had previous heart operations. So let's say the patient has had bypass operation or a valve operation, such in this case, and you have a lot of adhesions. An option is to do the operation different through a left lateral approach with the outflow graft then connected to the descending aorta.
The case we want to operate today is an implantation of an HeartMate 3 left ventricular assist device through left lateral
let's
approach.
See if I can take off. Can you still hear me? I think so, yes?
Yes.
Okay, good. So this is a patient, 64 years old, and he had mitral valve replacement and also an epicardial AICD through the left lateral approach. And is in chronic atrial fibrillation, we are class 4, Intermax class 3. Let's see, I advance a little bit. This patient is operated with cardiopulmonary bypass. Here we see the echo. You see the pacemaker leads, and the patient has a mitral valve implant in place. Let's advance a little bit. And here you see the setup. So we have made a left lateral thoracotomy, and already the aorta is exposed. You see here all the adhesions have been taken down. The lung is out of the way. This is the diaphragm, here's the heart, and here's the descending aorta. And this is also a good approach for patients. We had a patient last week who had a core valve in place and a very calcified ascending aorta and aortic arch. And we choose the same axis. So in order to avoid clamping of the ascending aorta. Here again, you see the echo, large left ventricle. You see the mitral valve prosthesis, which is still functioning. And now we look for the apex of the heart. Maybe I go back real quick because let's see. What you can see here is that the finger is impressing the left ventricle. Okay, so that's the finger test to get an information for the orientation of the inflow cannula. What you want to avoid with the inflow cannula is that it is directed towards the septum, because when the system starts to suck, it can actually suck the septum into the inflow cannula, which may then result in a decrease of flow. Also, you have to be sure to identify the LAD, and because the stitches at the septum, you want to really have deep bites, and it's sometimes not avoidable to include the LAD. One should not try to stay on the left side of the LAD just to save the vessel, because then these sutures will probably not be strong enough. So we're not afraid of occluding the distal LAD with the ring sutures. So then the ring is placed, and now we have a tangential clamp on the descending aorta, and the aorta is opened. The patient is on peripheral cardiopulmonary bypass, so we have to be careful when you put this clamp that you do not obstruct the complete flow, which we haven't in this case. And then the outflow graft is trimmed, and the anastomosis to the descending aorta is performed. This is a hard made, so you notice that the outflow graft is a little bit bigger in size, and you really have to make a long cut here, about 2 to 2.5 centimeters, in order to make a good anastomosis to the descending aorta. This is a pretty straightforward technique. Let's see if I can advance a little bit. So these are the last stitches. Of course, there is very limited space, and you need these retractors to be able to have enough room to do your anastomosis. If there's any questions, just interrupt me anytime. So that is no problem.
All right, Professor.
So here you still see the old pacemaker lead. So now we have we tunneled the drive line. The system is checked. And again, the most critical moment is when you core the left ventricle and put the device in. This can be a little bit tricky with the HeartMate because it's somewhat bigger. And of course, you have to have the mechanism. So we do some backward flushing maneuver. So we flush the system through the descending aorta. You see blood coming out of the device. Then also we use rapid pacing so that the ventricle is not really contracting. And note that we have a special instrument to stabilize the ring so that you don't push the heart away. So the coring has been done, and now the system. We inspect the left ventricle, of course. You want to avoid any thrombus here. So some patients who have these huge ventricles have thrombus. Also, any trabecula that could potentially obstruct the inflow cannula need to be resected. So we inspect the left ventricle. And if there's any residual trabecula, you can then resect them easily. And since we're on pump here, it's a little bit less stressful to actually put the system in. And for the heart mate, you have here this locking mechanism. Once the system is in, all you have to do is pull that locking mechanism and the system is connected. There's a de-airing maneuver, and then the system can be started. The patient is then weaned from bypass. You see immediately we have sufficient pump flow here. And good device function. You also see that the left ventricle is already decompressed. There's still some degree of tricuspid regurgitation, which is of concern, of course. And we can discuss what we do in those patients where the right ventricle becomes a problem. Here, of course, the tricuspid regurg is also caused by some of the leads that are in the way, but the right ventricular function is not all that bad. This is another case that we may actually skip because it's pretty much similar. Let's see if there's anything reasonable to show here. We just go right in. It's a similar case. Also bilateral implantation here, in this case of a heart mate. You've already seen the technique, so two surgeons can actually work in parallel, one on the aortic anastomosis and somebody else on the apex. So it can be a very quick procedure if you have enough people to work together and you trust them, of course. So again, the ring is fixed to the apex. The ring of the heart mate is a little bit bigger. Here you see the outflow graft that has been connected to the aorta. Again, this is the special tool that we have. And this is implant of the system. Since it's done beating hard again, it's a little bit bloody once you core. And when the system is in... okay, yeah, we can, there was nothing really else to show. What we also have is available now is the short-term support devices, and the most promising are the Impella systems. So this system sits in the, can be inserted transfemoral, the small one, this which is a partial support system, 2.5 liters. It's mainly used for venting of the left ventricle in patients who are on short-term extracorporeal life support. Let's say you have someone who is resuscitated, needs ECMO therapy, and then the heart is not pumping really. Then it may be necessary to vent the heart, which is difficult to achieve. We have tried various things, putting a vent through the apex, but it's always a little bit unstable situation on the ICU. So now we prefer to put in an impeller from the groin through the femoral artery. It goes through the aortic valve and can pump 2.5 liters of blood from the left ventricle into the aorta. The larger system here, the 5-liter version, and there's now a 5.5-liter version, also sits in the aortic valve and sucks the blood out of the ventricle and pumps it into the ascending aorta. And this system can actually support the heart fully if in cases where the left heart is the problem. And we have been using it for short term mainly, but we have also used it in some patients for a couple of months. And I give you an example. We had a young patient with an LVAD who got a severe infection of his device, which required that we had to take the full system out, including the inflow cannula, the drive line, and LVAD. and open wound treatment. So he had really a very bad system infection. And of course, it's impossible to put an LVAD in immediately. Also, you can imagine that this patient, you can of course put him on ECMO for, let's say, a week or two, but you cannot continue ECMO therapy more than 2 or 3 weeks because there will be complications. So we decided to put in one of these systems and keep the patient for 3 months on the system until his wounds were healed, and then implanted another LVAD. So here you see implantation of the Impella system through the axillary artery. This is of course a pacemaker lead, the TE probe, and now comes through the axillary artery. You advance the system. You see here the nose cone, and you see the pump. So this system now sits in the left ventricle. This part sits in the aortic valve, so the outlet is then in the ascending aorta. And this can all be done through the axillary artery. This is a case example of a male patient who also had an Impella. And it's also a good device, let's say, for some patients with myocarditis, because we know that some of these patients will recover and after a few weeks of appropriate therapy can be weaned. And of course, an LVAD implantation is much more invasive and also is maybe unnecessary if the patient has the potential for recovery. So here you see the patient walking around with his Impella, which is implanted through the axillary artery, as you can see. And so this small pump can actually support the patient so that he's fully ambulatory and can walk around the ward. So I think it's quite an interesting concept, which is now fully explored, and the new 5.5 liter system is meant for up to 6 months support, and eventually patients will probably also be able to go home. Of course, there's always a risk if the system can dislocate, and that of course puts the patient at very high risk for low output. Typically that can happen with mobilization or with pull on the system. So you have to be very sure that you have a very good tight connection and a stable position of the device. And currently the company is trying to improve the design so that dislocation is addressed. In Berlin, we have experience with now more than 3,000 pumps and 2,500 patients, and we have put in all of the devices that you see here. Most of them are no longer available. We also have some experience with the line heart, the first total implantable heart, and all the other systems that you see here, including the Jarvik, the old HeartMate versions, and other systems. We still use this for the pediatric population because in kids, of course, despite the fact that the hardware and HeartMate are very small pumps, for very small kids and newborns, these systems are too big, and therefore we use the X-Core device, and I can show you an example of this. Now, what can we achieve with LVAD therapy? Here you see a typical patient in end-stage heart failure. He looks like a cancer patient. You see the metabolic waste. There's no more muscles. This patient cannot walk around anymore. He has an output of 1.2 liters, which basically means he can only rest in bed. And he started to have cognitive dysfunction. And this is the same patient 6 months after his implantation of an LVAD. You can see that he is already in much better shape, so his metabolic function is much better. He has regained some muscles, and you see also that he gained some weight. The nutritional status is better, and he's of course fully ambulatory. So this is a good example of how effective this treatment can be. This is another patient of ours, a young man who had also a HeartMate implantation, and he was able to skate with the system. So he participated in the 20-kilometer Berlin Marathon for skaters. Of course, he was not the fastest, but he was fully mobile. He's transplanted by now. This is the situation I was talking about. We also treat very small kids, like you see here. And of course, these kids are too small to implant a pump. Therefore, we need to use X-core systems. And these systems have two valves here and a membrane that moves. So here's a gas chamber, which compresses a gas, which moves the membrane, and then the membrane pushes the blood out. And when the membrane relaxes, more blood comes in. So that's, and that is our smallest patient ever who received an early version of the hardware system. So you need to be at least 13, 14 kilograms to have a hardware implant. We have a number of these kids in-house. They wait for transplantation, which in Germany can take up to 2 years waiting time. And of course, these patients cannot be sent home with these devices. We also treat a growing number of old patients. You see two gentlemen here, age 76, 72. Those patients have, of course, no indication anymore for transplant, but the system is used as destination therapy. In some patients, we can use also continuous flow pumps for biventricular support. And this is a CT and a chest X-ray of a patient with 2 pumps. You can see a left and a right pump. Typically, here for the right pump, the pump is put into the right atrium or the right ventricle, and the outflow graft goes to the pulmonary artery. This is a young gentleman with 2 pumps. Currently, we put between 120 and 140 LVADs in patients. This year, we will probably have more than 140 implants to the end of the year. Exclusively LVADs these days. We have very little experience with total artificial heart, which we see only very rare occasions in indications. With this growing number of implants, of course, we have more patients on the device. Currently, in our ambulatory setting, we have 350 patients who are actually on the device and come for regular visits to our outpatient center. The survival with LVAD has increased substantially over the last couple of years. This is an overview of some of the early trials. You see here the first one that compared medical therapy and pulsatile flow. The rematch trial showed a survival benefit for LVADs as compared to medical therapy. Then the continuous flow devices showed a better outcome than the pulsatile devices. So already for these early continuous flow devices, you see a 6-month survival of 80%, 1-year survival of about 70%. And the newer generation of devices, if we compare this now, this is from the lateral trial, 1- and 2-year survival rates of 89% and 87%, which is really good. And compare that to the survival rate of patients who are untreated or medically treated, which is much worse, of course. Also, length of stay in hospital has substantially decreased over the years, and typically these patients can go home after 2 or 3 weeks. Other data from the Revolve Registry show the long-term outcomes up to 7 years, and you see that even after 7 years, the survival is 50%. It's still less than transplant outcomes, but at least for the first 2 years, it seems that the LVAD population matches the transplant population when it comes to survival. We have experience now with the HeartMate 3 and almost 200 implants or more than that. I can't remember right now the exact figure. We have published also the CE mark trial with the HeartMate, and you see that we had a 6-month survival of about 90% and 1 year survival of 85%, which is excellent for this very sick group of patients. The Momentum 3 trial that compared centrifugal flow pumps and axial flow pumps, so the old HeartMate 2 with the HeartMate 3, shows pretty much similar survival, no big difference. There is a difference, but not significant, in favor of the newer devices. And stroke rate is also similar. We have compared, not in a randomized fashion, but propensity matched our results with HeartMate and HeartWare, and we couldn't find a difference in survival for the two systems, really. Survival in general is very much depending on the Intermax level. You see here the different Intermax levels. For those who don't know what Intermax is, it's a classification system that stratifies the patients according to the severity of shock. Intermax level 1 is the sickest population. These are patients in cardiogenic shock that need immediate resuscitation or ECLS support. And it goes down to Intermax level 6, and those are the patients who are in NYHA class 3 and at home. So for those patients who are in Intermax 3, that means inotrope dependent, we have a 70% survival after 3 years. So what's our solution? And I think LVAD therapy has its merits, but also it has, of course, a lot of complications. What we infrequently see is driveline infections, but this is a notorious problem. The patients will come back multiple times. There's no good solution for this. Debridement, of course, local wound therapy. And sometimes you have to really cut this open and put the driveline at a different location and do a plastic closure here. Then, of course, related to the systems, the risk of cerebral bleeding with anticoagulation, but also with stroke due to pump thrombosis, which is a very bad problem. Also the problem of right heart failure, and of course device failure, which doesn't happen too much with the newer generation systems, but I will show you also an example how this can look. So we have to deal with all these complications, and this is a little bit outdated, so the results have improved, but just to show you that at 12 months, only 30% of the patients are absolutely free of any of the complications, infection, bleeding, device malfunction, stroke, or death. So most of, excuse me, most of the patients at some point in their course will have one of these complications. What are the risk factors for death after LVAD therapy? This is a complicated slide, so we take it down. These are the factors that are really related to survival post-LVAD. This is age, of course. If the patient needs preoperative ventilator support, of course, this is an indicator for advanced disease, be it due to pulmonary edema, cardiogenic shock, or any other reason. Intermax level 1 and 2, so these are the patients in shock. Those patients who present with renal failure, and the worst group is those patients who do have also right ventricular failure. To illustrate that, this is renal, this is right heart failure. You see that those patients with severe right heart failure have a much worse survival. This is renal function, and you see that even a moderate creatinine increase has already an impact, and those patients who have are on dialysis have already after 6 months have a survival of only 60%, and after 2 years only 40% are still alive. So renal failure is really a complicated matter which probably should impact our decision making. I show a few other problems that can happen. This is the log of the LVAD, and you see that there was continuous normal function. Then you see a decrease in the outflow any flow values. And the reason for this, you see here, if you focus on this, you see that we inject contrast media into, we have advanced the catheter into the outflow graft. And you see that here is no contrast because there's a big thrombus right there where the system, where the outflow graft starts. And you can also see it here in a short axis view, and you see it here on the CT scan. So in this case, we were able to remove that thrombus, and you see now that there's no restriction in flow and the pump flow recovered. This is another example also that we have detected. What you see here is that there is a restriction of flow due to a fibrin mass between the outflow graft and the graft protector. And you can see that in this image, you see how the graft is compressed. And in this case, what you need to do is you reopen the graft protector. So you don't have to change the system for this. You just do an incision, open the graft protector, this plastic shield, and this will release the pressure on the outflow graft. Another interesting phenomenon you see here, this is an outflow graft twist. This is very tricky. You would think that this would happen immediately after surgery, but we have seen a number of patients 1.5 years after surgery with definitely no kink when they left or no outflow graft twist. But this happens because there was a construction problem with the HeartMate 3. And it was possible that over time, the outflow graft moved at the connection to the system and resulted in a twist like this. And you see this here on the CT scan. And so in this case, you have to open again and then release this twist, or what we did in this case, we even made it worse. We tried to solve this problem with a stent, and the stent actually solved the problem at this level, but then the twist is moved downwards. You see it right here. So in this particular case, we had to exchange the pump then. This is another problem that can occur, which is a neo-intima dissection in the outflow graft. So you see it is an obstruction right there at the anastomotic site. There was no problem in the beginning, but there was neo-intima formation within the outflow graft, and that neo-intima dissected and occluded the anastomosis. So this, of course, can be stented, and you see here that a stent was inserted, and this actually solved the problem. Another problem, which is kinking of the graft. So if the outflow graft is too long, there can be a kink. And that, of course, can be corrected with a redo operation and shortening of the outflow graft. A few words to the total artificial heart. The CardioVest is a very old system, basically designed in the 80s, but is the most frequently implanted. You see here worldwide, and this is an old slide, it's probably much more now, more than 2,000 implants. And of course, it's a biventricular system, and the chambers are connected to the atrioventricular cuffs. And some of these patients have been on support for at least 2 or 3 years. And you see here the survival. These are data from Paris. So after 6 months, about 50% of the patients were still alive. Meaning that 50% died actually. The main complications you see here, stroke in 10%, mediastinitis, infection, and finally discharged home only 14%. So that's a pretty poor outcome, which illustrates that total artificial heart should just be a bailout procedure. These are data from Bad Oeynhausen that show the same. Also, total artificial heart implants. You see here that after 6 months, 50% of the patients were already dead. Some were transplanted. You see here 20% were transplanted, but after 12 months, 23% of the patients were ongoing on support. So quite high survival, really a bailout procedure. There's now a new driver for the system, which makes it a little bit easier to use. The old system had really big, and loud drivers. That was very difficult for the patients to handle. A newer system is the CARMAT, and you may have seen this. This is a quite masterpiece of engineering. It's also a total artificial heart. It is meant to be a physiological heart replacement therapy, so it has some sort of auto-regulation. It acts instantaneously on information it receives from internal pressure sensors that are distributed within the system. It is pulsatile and largely hemocompatible because all blood interfaces are made out of pericardium, so bioprosthetic materials that we know from heart valves on all blood contacting surfaces. And this will also reduce the shear stress for the heart, for the shear stress for the blood components. It is an electrohydraulic system, so it's quite silent in operation. It's of course connected with the driveline through controller and the batteries. And the batteries are small enough so that it can be, the patient can walk around, and the batteries last for 4 hours in the old system. So this is the principle of how this system works. You see there's 2 motors, and there's 2 membranes here that are alternately pushed by these motor drives. There's a fluid here that is moved by the motors, and this creates then the flow. There's 4 valves, but in this case biological valves, also made out of pericardium. And there's some pressure sensors placed at the in these chambers, and if the pressure changes, there's a flow adaptation and the flow is controlled. So there's a feedback loop that helps to control the system. And this is the biologic components. So the atrial connection is made out of pericardium. These are the valves. These are typical carpal efforts biovalves. This is the hybrid membrane, also made of pericardium, and this is the shell. And there is very little hemolysis, and there's some neoendothelialization of the membranes that could be demonstrated. What we see is real-time pressure and flow information on the screen, and this system can pump up to 10 liters of flow. There is an adaptive behavior, which you can see that these are days of operation. And you see that the circadian rhythm in terms of the flow during nights, the flow goes down, during day and activity, the flow goes up. So there is really an adaptive behavior of the system. And you can see it also for the hour. If you break it down for 1 day, you see that during the activities, during daytime, the flow is higher. Then when the patient goes to bed, it comes down. So this is a typical behavior of the system. The initial experience was a little bit disappointing because for technical reasons, the patients died. But there's a new series now running, and some of these patients have been on the system for more than a year now with no technical problems. And some have even been discharged at home or transplanted successfully. There's a new concept also that will enter clinical trials hopefully soon. It addresses also all the complications that I have already mentioned. And it is different from the continuous flow devices that we typically implant. Excuse me. What the continuous flow devices do, there's a rotating impeller with electromagnetically levitated, so within an electromagnet it rotates, but due to its size it needs high velocity, and this produces high shear stress. And of course, there's no pulsatility. And this system called CoreWave.
CoreWave NIP2 is an implantable left ventricular assist device
is a completely different mode of operation, as you can see here. The system basically also has a magnet, so it's magnetically activated, but instead of a rotor, there's a membrane that creates this wave front within the blood. So the blood is actually moved by a membrane. It looks almost like a wing from a bird, it propels the blood with much less velocity, and of course it creates a high fidelity pulsatile flow. And if you look at the pressure curves, they almost look like normal pressure curves. So the system is also implanted into the apex of the heart, like the heart made in the hardware. And it's relatively small, so not different from any of the current devices, but the mode of action is completely different. So here's the principle again. You have an electromagnet which moves the system up and down, and this induces a wave motion of the membrane, which then leads to a blood flow. And if you compare to the normal heart, where the blood flow has a physiologic flow speed of about 1 to 1.5 milliliters of flow, milliliters per second, and the pressure difference between systole and diastole is about 30-35 millimeters. You can pretty much mimic this with this system. So the flow speed is the same, and the pressure difference that you can achieve with the system is also very similar. Also, the pressure increase is very fast, and this is completely different from the rotary pumps, which operate at a much higher speed, propel the blood with higher speed through the system, and cannot create real pulsatility. By changing the rotations, you can induce a pseudo pulsatile flow, but it's still the acceleration is still much longer than for the normal heart or for the CoreWave system. There's no clinical data yet, but animal experiences are promising. No thrombus formation, and it is expected that we have the system available hopefully in the next coming years. Berlin Heart, a company based closely where I live, is also working on new systems. They are developing a similar device, continuous flow device with also integrated pressure measurements, so sensors. And they're a little bit smaller even than the HeartMate 3 or the hardware. But unfortunately, they're not available clinically yet. What is innovative in these systems is a new rotor design, which should decrease the shear stress and the platelet activation, and should hopefully decrease the bleeding events and thrombosis events. In the chronic preclinical testing, the outcomes are quite promising, but no clinical data yet. There's some gimmicks that will help implantation. For the left lateral thoracotomy, a different coring device will become available for the hardware, which is not a major breakthrough, but what will help is that there's now a more flexible cable. The stiffness of the cable is sometimes a problem and probably a trigger also for the driveline infection. We will make more use out of the log files of these systems because a lot of information can be retrieved from the log files. If you use machine learning and artificial intelligence, we'll probably be able to recognize pump-related problems earlier and call the patient in to for example, start a lysis protocol if we have the suspicion of pump thrombosis in an early stage, this will usually do the job. If the patients come too late, then a backwash maneuver is needed or even a pump replacement. So there's a lot of hope that by thoroughly analyzing these log files that can be remotely accessed, that we can facilitate management of these patients. The controllers will become smaller, also the battery packs will become smaller, so that the patient comfort will increase. And as I said, we will have the opportunity to get all these data easily through mobile phones and apps, so that then the patient can be better monitored. Also, hardware was working on a smaller device, which also didn't make it quite. The CE trial was put on hold for some technical problems. And there's multiple configurations that we can think of in the future. Also partial assist systems or coming through the through the atrial septum and subclavian artery. So there's many potential configurations in the future that we can think of. Of course, the Holy Grail is a fully implantable system, but that would require that we have not only a battery that is big enough and can be implanted, but also that, that we have good coils for transcutaneous energy transfer. And there's now a system available from Israel, and first 2 patients have been implanted in Astana in Kazakhstan, where the coil was implanted and connected to a Javik system. That's an older pump system. And these 2 patients were completely ambulatory, and the system was completely implanted. So it is possible to get rid of the drive line, get rid of any connection of the system to the outside. I'm not going into my research now because I think we have now almost an hour. I will just mention that we have a research program together with the ETH, the engineering school in Zurich, and the German Heart Center, which includes a lot of different departments from the engineering school in Zurich, where we work on pump design, control sensor technology, fluid dynamics, biomechanics. We use different materials and new methods from electrical engineering to design a new artificial heart. But I have to say that we're not very far. We are still in an early phase and haven't come to a system that is completely useful, but we have solved some of the components. For example, we have solved the TED problem. We have a energy transfer system. We have integrated sensors into the outflow cannula, so we can actually close the feedback loop. We have very intelligent control algorithms designed. All this is applicable for a pump, and we're still designing these. There's 2 options: to do another continuous flow pump, or what we also think of as a very small implantable pulsatile device, but that is work in progress. So with this, I would like to thank you for your attention. I hope you're still there. And if you have any questions, I'm happy to try to answer them. Thank you very much.
Thank you very much, Professor Volkmar Falk. It's a pleasure to have you presenting this awesome presentation. And just one question we would like to ask you. And how long does it take to a patient with indication for heart transplant to get one in Germany right now?
Hang on. Okay. So in Germany, it takes for someone, we have 2 different status in Germany. One is high urgency. These are patients who are in hospital and allotrope dependent and cannot be discharged, so they get in high urgency status, and they will receive a heart within 3 months usually, but it can take also longer. And the other group of patients with elective status who are at home or on an LVAD and stable, it will take 2 to 3 years for them.
Yeah.
So we only do 300 transplants in Germany, and we have many more patients waiting for transplants. So we cannot fulfill the demand, and therefore we need LVAD systems.
Yeah, as you said before, in your ambulatory, in your center, there are probably 350 patients
on the system. Not all of them are candidates for transplant. A lot of them are on lifelong therapy. But of course, we have also a number of patients on the transplant list, bridge to transplant.
Yeah, this is because of the amount of patients we've had right now in Germany.
Yeah.
Yeah. That's it. Thank you very much, Professor. It's a really pleasure to have your ominous presentation to us. Thank you. And this presentation is going to be online on the YouTube, and you can share with your public in Germany and also with your team if you want. Thank you very much, Professor.
Thank you. Good night. Bye-bye.
Good night. Have you a great weekend. Thank you.